Welcome to Endocrine Disorders Part 1, Disorders of the Pituitary and Thyroid Gland. Please note the SLOs guiding this lecture include assessment, professionalism, and safety. Other SLOs guiding this lecture include patient-centered care, evidence-based practice, teamwork and collaboration, and informatics. The endocrine system is comprised of many glands, the pituitary gland being the master gland. Which hormone is produced in each one of these glands? The pituitary, the thyroid, the parathyroid, and the adrenal. Please write down your answers and begin to make charts for your own study. So what do hormones do? They regulate the flight or fight syndrome, they regulate fluid and lights, they regulate glucose metabolism, they regulate mood and digestion. These are just some of the functions that hormones participate in. Hormones are classified into 4 categories according to their chemical structure. Amines or epinephrine versus proteins such as thyroid-releasing hormone. The other 2 categories include corticosteroids and fatty acid derivatives. When studying endocrine, please be familiar with the following endocrine facts: the name and function of the specific gland and the name and function of the hormone produced by that gland. Please note the pituitary gland is called the master gland because of the influence it has on many other endocrine glands. Please note the location of the pituitary gland at the base of the brain. Therefore, any brain injury occurring at this level will affect the pituitary gland and its subsequent function and response to other glands. The hypothalamus is highly involved in pituitary gland function. When it receives a signal from the nervous system, the hypothalamus secretes substances known as neurohormones that start and stop the secretion of pituitary hormone. The pituitary gland is involved in several functions of the body, including growth hormone production, production of hormones that act on other endocrine glands, production of hormones that act on the muscles and the kidneys, endocrine function regulation, storage of hormones produced by the hypothalamus. The anterior lobe of the pituitary gland releases hormones upon releasing or inhibiting hormones from the hypothalamus. These hypothalamic hormones tell the anterior lobe whether to release more of a specific hormone or to stop production altogether. The hormones produced in the anterior lobe of the pituitary gland include ACTH, which stimulates the adrenal glands to produce hormones, FSH, which works with LH to ensure normal functioning of the ovaries and testes, growth hormone, which is essential in early years to maintaining a healthy body composition and for growth in children. In adults, it aids healthy bone and muscle mass and affects fat distribution. Produces LH, luteinizing hormone, which works with FSH to ensure normal functioning of the ovaries and testes. Prolactin, which stimulates breast milk production. Thyroid stimulating hormone, which stimulates the thyroid gland to produce other thyroid hormones. The pituitary gland is involved in several functions of the body, including growth hormone production, production of hormones that act on other endocrine glands, production of hormones that act on the muscles and kidneys, endocrine function regulation, storage of hormones produced by the hypothalamus, which occurs in the posterior pituitary gland. In hyperpituitarism, the pituitary is overactive, producing hormones in excess. An overproduction of growth hormone may result in acromegaly in adults. This condition results in excessive growth of bones and tissues in the hands, feet, and face. In children, the overproduction of growth hormone may result in gigantism. Acromegaly is usually caused by the pituitary gland producing excess growth hormone. In more than 95% of the cases, the excess production is due to a benign tumor, known as a pituitary adenoma. The condition is not inherited from a person's parents. Rarely, acromegaly is due to a tumor in another part of the body. Gigantism and acromegaly are both disorders linked to an overactive action of insulin-like growth factor. Gigantism occurs when abnormally high growth occurs during childhood, when the epiphyseal growth plates are open, whereas acromegaly is due to the same action occurring in adulthood when the growth plate cartilage has fused. An abnormality in the pituitary gland results in an oversecretion of growth hormone, which in adults leads to an enlargement of bones and in children also leads to excessive height. If acromegaly is related to a pituitary tumor, the client will experience increased intracranial pressure as well as increased blood glucose levels. Acromegaly is a hormonal disorder that develops when your pituitary gland produces too much growth hormone. Although uncommon, it does occur during middle adulthood. When this happens, your bones increase in size, including those of your hands, feet, and face. A common side of acromegaly is enlarged hands and feet. People with this disorder often notice that they aren't able to put on rings that used to fit and that their shoe size has progressively increased. Acromegaly may also cause gradual changes in the shape of your face, such as a protruding lower jaw and brow, enlarged nose, thickened lips, and wider spacing between teeth. Because acromegaly tends to progress slowly, early signs may not be obvious for years. Sometimes people notice a condition only by comparing old photographs with new ones. In hypopituitarism, there is a lack of one or more of the pituitary hormones. If all the hormones are deficient, it is called panhypopituitarism. If it is only one of the hormones, then it is selective. For example, if just growth hormone is decreased in childhood, we have a phenomenon called dwarfism. If the TSH is decreased, then we have a decrease in the normal function of the thyroid gland. Hypopituitarism may be caused by brain surgery, brain tumors, or head injuries, just to name a few causes, in addition to metastasis of cancer to brain cells. Just to reiterate, pituitary dwarfism is caused by a discrete lack of growth hormone. Efforts to reverse dwarfism in children include giving human growth hormone and or inserting DNA sequence into children to cause them to produce their own human growth hormone. Please review this chart regarding anterior pituitary disorders. Review which hormones are implicated in each disorder. In other words, which hormone goes up, which hormone goes down. Most pituitary tumors are benign. The tumors may either be primary or secondary and functional or non-functional. Functional tumors secrete pituitary hormones, whereas non-functional tumors do not. Surgical removal of the pituitary gland, hypophysiotomy, through a transsphenoidal approach is the usual treatment. The location and effects of these tumors on hormone production by target organs can have life-threatening effects. 3 principal types of pituitary tumors represent an overgrowth of either eosinophilic cells, basophilic cells, or chromophobic cells. Please see this pictorial representation of the pituitary gland and its effect on other glands throughout the body. We will now begin to talk about some disorders of the posterior pituitary gland, such as diabetes insipidus. Diabetes insipidus is caused by a deficiency in a hormone called the antidiuretic hormone. ADH, also called vasopressin, regulates the amount of fluid in the body. This deficiency could be the result of damaged or injured pituitary gland or hypothalamus. Tumor or infection of the pituitary gland, a genetic disorder, kidney problems such as chronic kidney disease, and certain antiviral drugs. Common signs and symptoms of diabetes insipidus include severe thirst, frequent urination where excessive diluted urine is excreted, bedwetting, inconsolable crying in children, trouble sleeping, fever, vomiting, diarrhea, delayed growth in children, weight loss and malnutrition. Think about what happens when there's too little ADH or antidiuretic hormone. Too little antidiuretic hormone means too few messages to the kidneys, which in turn means the kidneys will keep too little water in the body. So think about what signs and symptoms this will lead to in the patient. Think about some of the nursing actions required to manage a patient with diabetes insipidus. Some of these include monitoring I&O, replacing fluids, checking the neurological status, checking labs, monitoring vital signs, looking for signs and symptoms of hypotension and tachycardia, assessing mucous membranes. The objectives of therapy with the patient with diabetes insipidus are to replace antidiuretic hormone, to ensure adequate fluid replacement, and to identify and correct the underlying pathology, because diabetes insipidus is not a standalone disease. It is a disease related to some other pathology, such as a brain tumor or a traumatic brain injury. The objectives of therapy with the patient with diabetes insipidus are to replace antidiuretic hormone, to ensure adequate fluid replacement, and to identify and correct the underlying pathology, because diabetes insipidus is not a standalone disease. It is a disease related to some other pathology, such as a brain tumor or a traumatic brain injury. Desmopressin nasal spray is a drug of choice when treating the patient with diabetes insipidus because of its vasoconstrictive effects and lack of systemic effects as opposed to IV vasopressin. I just want to remind you of an important concept alert. It is important to distinguish between diabetes insipidus, which is a disorder of insufficient output of pituitary antidiuretic hormone, and diabetes mellitus, a metabolic disorder characterized by hyperglycemia caused by deficient insulin secretion or action or both. Now we're going to talk about SIADH. SIADH is the direct opposite of diabetes insipidus. So if diabetes insipidus causes fluid volume deficit, what does SIADH cause? Fluid volume excess. So think about that patient with SIADH being volume overloaded. What are the signs and symptoms that that patient is going to manifest? What are some of the interventions that are going to be useful when dealing with this particular client? As is the case with diabetes insipidus, SIADH is not a standalone disease. It is a disease related to something else, such as head injury, neurological infections, pulmonary infections, side effect of cancer, particularly lung cancer. These are just some causes of SIADH. Let's think about some of the things that increase antidiuretic hormone cause: a decrease in urine volume, an increase in urine osmolarity, an increase in blood volume, an increase in blood pressure, a decrease in blood sodium or hyponatremia related to dilutional causes, a change in mental status. Because when you're thinking about changes in sodium, you're thinking about changes in the neurological system. Just to reiterate, some of the signs and symptoms of SIADH include high blood pressure, weight gain, oliguria, and hyponatremia. Nursing care for the patient with SIADH includes monitoring of vital signs, monitoring of I&Os, monitoring daily weights, and intervening where appropriate. Hyponatremia nursing care includes monitoring the mental status for any changes such as confusion, seizures, lethargy. In addition, for fluid overload, monitor vital signs, particularly assessing for hypertension, edema, shortness of breath, or any sign and symptom of circulatory overload. Surgical management of the patient with SIADH includes removal of the posterior pituitary gland in order to decrease the amount of circulating ADH in this patient. Look for the complication of diabetes insipidus post-posterior pituitary surgery removal, because now there's the very real possibility that there won't be enough ADH. When comparing and contrasting diabetes insipidus to SIADH, we see that this is a perfect contrast of fluid volume deficit to fluid volume excess. Diabetes insipidus being fluid volume deficit and SIADH being fluid volume excess. Please review these previously learned concepts to further study this content. We are now going to switch gears and start talking about the disorders of the thyroid gland, which by and far are much more prevalent than the disorders of SIADH and diabetes insipidus. The thyroid is the largest endocrine gland, is a butterfly-shaped organ located in the lower neck, anterior to the trachea. It consists of two lateral lobes connected by an isthmus. The gland is about 5 centimeters long and 3 centimeters wide and weighs about 30 grams. The thyroid gland produces 3 hormones, T3, T4, and calcitonin. In order for thyroid hormones to be made, the hypothalamus releases thyroid-releasing hormone to stimulate the pituitary gland to release thyroid-stimulated hormone to stimulate the thyroid gland to produce and release T3, T4, and calcitonin. T3 and T4 make up thyroid hormone. Thyroid hormone is stored in the thyroid gland. Thyroxine-binding globulins bind and transport thyroid hormone when needed in the bloodstream. Please see the ranges of the normal markers of TSH, T3, T4 on this slide. However, these ranges might differ from the ones in your textbook. For study purposes, please follow the ranges in your textbook. Thyroid antibody tests are important to distinguish if somebody's thyroid condition is autoimmune in nature. For example, hypothyroidism, autoimmune disease, is called Hashimoto's. Hyperthyroidism, autoimmune disease, is called Graves' disease. Another important hormone produced by the thyroid gland is calcitonin, which is released in response to high calcium and decreases the plasma calcium by increasing the deposits of calcium in the bone. The secretion of T3 and T4 by the thyroid gland is controlled by TSH from the anterior pituitary gland. TSH controls the rate of thyroid hormone release through a negative feedback mechanism. In turn, the level of thyroid hormone in the blood determines the release of TSH. If the thyroid hormone concentration in the blood decreases, the release of TSH increases, which in turn causes increased output of T3, T4. Iodine is essential to the thyroid gland. Its deficiency in the American diet is a major contributor to thyroid dysfunction. So a little bit about thyroid physiology. T4, 80% is its inactive form of thyroid hormone. T3, 20% is the active form of thyroid hormone. Production is stimulated by thyroid stimulating hormone, which is stimulated by thyroid releasing hormone. After the hormone is produced, thyroid binding globulins transport the thyroid hormones to the tissues and exert its metabolic effect. A simple goiter is an enlargement of the thyroid gland. It is usually not a tumor or cancer. It usually causes no symptoms except for benign neck swelling. Some thyroid glands are nodular because of areas of hyperplasia or overgrowth. These areas can potentially become cancerous growths. No symptoms may arise, or some may descend into the thorax where they cause local pressure symptoms. Some nodules become malignant, and some are associated with a hypothyroid state. Increased amount of nodules may precipitate the need to require surgery. Thyroid ultrasound uses high-frequency sound waves to take a picture of the thyroid gland, showing if there's any nodules or abnormalities. Symptoms of hypothyroidism primarily develop in females over age 40. They tend to develop slowly. Commonly noted symptoms include fatigue, weight gain, increased blood cholesterol, increased sensitivity to cold, constipation, dry skin, puffy face, hoarse voice, muscle weakness, aches, tenderness, joint pain, irregular menses, hair loss, just to name a few. When talking about hypothyroid disorders, Hashimoto's is a very common autoimmune cause of hypothyroidism in adults in which the antibodies attack itself. Just to reiterate, hypothyroidism most commonly occurs in women in the age group from 40 to 60. Some of the common symptoms include fatigue, weight gain, brittle hair, thickened skin, thickened nails, loss of libido, scant menstrual cycles, constipation, slow and cold. Severe signs and symptoms of hypothyroidism include hypotension, bradycardia, a decrease in temperature, a dull, expressionless, mask-like face, dementia, and eventually myxedema coma. Myxedema coma includes the most extreme symptoms of hypothyroidism, including hypotension, bradycardia, hypothermia, loss of consciousness, extreme mental status changes, with the potential for full cardiac collapse. Remember, myxedema coma is a rare life-threatening condition, even though it is the worst consequence of severe hypothyroidism. It may be precipitated by infection or other systemic diseases or the use or overuse of opioids. Per a head-to-toe exam of the patient with myxedema coma, the neurological status will be compromised. The patient will demonstrate increasing signs and symptoms of lethargy and stupor. The respiratory status will be compromised. The patient will be retaining PCO2, developing a severe respiratory acidosis. Fluid and electrolyte status will be compromised or unbalanced. Patient will be exhibiting signs and symptoms of hyponatremia and hypoglycemia. Eventually, cardiovascular collapse will occur. The patient will experience hypotension, requiring the use of vasopressors and external ventilation. The objectives of the management of hypothyroidism are to restore normal metabolic state by replacing the missing hormone, as well as preventing complications. Levothyroxine is administered based on the patient's TSH, either orally or injectable, again based on the patient's status. The main medication for hypothyroidism is Synthroid, which is the trade name, and levothyroxine being the generic. It's important to remember to take Synthroid in the AM on an empty stomach, and it has many interactions with other drugs. The dose is adjusted based on the TSH levels. Remember, the higher the TSH, the more hypothyroid the patient is. The lower the TSH, the more hyperthyroid the patient is. Now we are going to talk about hyperthyroidism. If hypothyroidism is slow and cold, what do you think we refer to hyperthyroidism as? Yes, you are correct. Fast and hot. The manifestations are fast and hot. Think intolerance to heat, high heart rate, high blood pressure, weight loss, increased energy, increased palpitations, increased tremors, right? Everything fast. People actually love this disorder because they feel like they have a lot of energy for the first time in their life until they start to feel the complications, which you can imagine would be cardiac collapse because of the increased heart rate, increased blood pressure, and so forth. So think hyperthyroidism, fast and hot. When we think of disorders of the hyperthyroid type, we think of thyroid toxicosis, resulting from an excessive synthesis and secretion of endogenous or exogenous thyroid hormones by the thyroid. Graves' disease is another example of hyperthyroidism, specifically autoimmune hyperthyroidism. It results from an excessive output of thyroid hormones caused by abnormal stimulation of the thyroid gland by circulating immunoglobulins. Very often, exophthalmos is associated with Graves' disease, bulging of the eyes. Some signs and symptoms of hyperthyroidism include nervousness, emotional hyperexcitability, irritability, apprehension, a fine tremor of the hands, and as mentioned earlier, exophthalmos. Other signs and symptoms of hyperthyroidism include increased appetite and dietary intake without weight gain, fatigability, weakness, amenorrhea, changes in bowel function, cardiac abnormalities such as primarily atrial fibrillation, sinus tachycardia, and some other dysrhythmias. In addition, myocardial hypertrophy and heart failure may occur if the hypothyroidism is severe and left untreated. Management of hypothyroidism includes antithyroid medications, radioactive iodine, and surgical procedures. The use of radioactive iodine is the most common form of treatment for Graves' disease in North America. Beta-adrenergic blocking agents such as propranolol or atenolol are used as adjunctive therapy for symptomatic management, particularly in transient thyroiditis. they are very effective with diminishing the experience of palpitations for patients. Surgical removal of the entire thyroid gland or part of it is a non-pharmacologic alternative commonly used to treat hyperthyroidism. See this great picture of exophthalmos, a prominent symptom in hyperthyroidism. Think about what nursing interventions are needed for this particular client. Radioactive iodine I-131 therapy is a nuclear medicine treatment for hyperthyroidism and also may be used to treat thyroid cancer. Over a period of several weeks, thyroid cells exposed to the radioactive iodine are destroyed, resulting in reduction of the hyperthyroid state and inevitably hypothyroidism. The use, on the other hand, of just an ablative dose of radioactive iodine initially causes an active or acute release of the thyroid hormone from the thyroid gland and may cause increased symptoms momentarily and then eventually a decrease in symptoms. Pharmacological management of hyperthyroidism includes using drugs such as methimazole or MMI or propylthiouracil or PTU. These drugs are given 4 to 6 weeks prior to the administration of radioactive iodine. The purpose is to slow down the thyroid. The antithyroid medications are stopped 3 days before and restarted 3 days after administering radioactive iodine and then tapered over 4 to 6 weeks. The patient is observed for signs and symptoms of a thyroid storm, a rare complication that can occur, which is manifest by cardiac dysrhythmias and neurological impairment. Beta blockers are used to control these symptoms. Thyroid storm can be severe, abrupt, and almost always fatal if left untreated, but with proper treatment, the patient can survive. Symptoms of thyroid storm include high fever, above 101.3, extreme tachycardia, above 130 beats per minute, gastrointestinal symptoms, weight loss, diarrhea, abdominal pain, cardiovascular symptoms such as chest pain, dyspnea, palpitations, altered neurologic or mental state, which frequently appears as a delirium psychosis or coma possibly. Immediate objectives of management of thyroid storm are reduction of body temperature and heart rate and prevention of vascular collapse. Some measures to accomplish these objectives include a hypothermia mattress or blanket, PTU or methimazole, hydrocortisone to treat shock or adrenal insufficiency, and iodine is administered to decrease output of T4. Thyroidectomy is a common procedure for hypothyroidism. Subtotal thyroidectomy, the surgical removal of about 5/6 of the thyroid tissue, is done to decrease the hyperthyroid state, reserved for those allergic to antithyroid medications, in patients with large goiters, or in patients who are unable to take antithyroid agents for some other reason. Surgery, therefore, is a treatment for hypothyroidism soon after the thyroid function has returned to normal, 4 to 6 weeks. Thyroid cancer is becoming more and more pronounced in our society. It accounts for 90% of endocrine malignancies. The research is pointing towards the increased amount of radiation we are exposed to on a daily basis as a possible reason for this. It is the fastest growing cancer among men and women. 3 of 4 cases occur in women. Unlike other cancers, 80% of new cases are in patients under the age of 65. External radiation of the head, neck, or chest in infancy and childhood increases the risk of thyroid carcinoma. The incidence of thyroid cancer appears to increase 5 to 40 years after irradiation exposure. Improved patient outcomes for patients with thyroid cancer are seen when management is through a team approach. To compare and contrast hyper and hypothyroid states, remember slow and cold for hypothyroidism and fast and hot for hyperthyroidism. This ends Endocrine Part 1. Please review the hormones discussed in this PowerPoint presentation to get a better understanding of the endocrine disorders discussed today.